Hello, my name is Malcolm Shainline, and I did my preceptorship at St. Joseph's Medical Center, primarily caring for PCU and ICU status patients in the critical care department. The title of my capstone is Nursing Care of the Critically Ill Patient with ARDS, or Acute Respiratory Distress Syndrome. I became interested in this topic because it's complex, both physiologically and how we care for these patients. It involves a lot of aggressive treatment and physiologically driven treatment. It's also uh, a great sort of arena for nursing in terms of critically thinking and providing excellent quality nursing care. I also had a patient who came in, a trauma patient who acquired sort of this ARDS deal after their injury. And when I was caring for this patient, I took a look at the ventilator and I didn't really understand the ventilator settings, or at least initially, I didn't really understand like why they were on those ventilator settings and why they were responding the way they were to the ventilator. And after that shift, I did some research and looked into it. It was bi-level ventilation. That was the mode. And so the parameters were not your traditional tidal volume and that sort of thing. It was more focused on pressure high, pressure low, time low. But I found that very interesting and intriguing, so I decided to do my project on it. One of the surprising things I found is ARDS is relatively rare, which is surprising, but it has a really high mortality rate, and with that mortality rate comes the associated costs of a hospital stay, getting that complex treatment, that ventilator support, potential paralysis, a very expensive hospital stay. So, and the mortality has not really changed all that much in the past 50 years. Um, which is interesting to think about. This project reinforced a lot of things for me. I think specific to nursing, I think it reinforced how important supportive care is, and how important assessment is. Supportive care in the sense that that's sort of the core of nursing in the ICU, is all that supportive care, supporting the patient's physiologic functions, and assessment more so in the sense that because we're in the room so much, we can assess sort of the patient's response to these therapies. We can assess if that ventilator mode and settings, if that is benefiting the patient, by careful assessment of various physiologic parameters. And we can suggest or push for adjustments in those therapies based on how the patient's responding. And that was another thing it reinforces, like individual treatment, really sort of trying to individualize the treatment to that patient and to that patient's response to whatever current treatment is, and adjusting accordingly to make it more effective and better, is of utmost importance to getting those positive outcomes that we all want. A couple key points that I think everyone should take away is supportive care is critical. It is like the key. It sort of provides the foundation for everything else. And same with assessment and adjusting those settings, or pushing for the adjustment of those settings accordingly. This is very nurse driven, uh, very critical. Another key thing, sort of along those lines, a little more specific to the ventilator, is ventilation strategies might vary a little bit, but generally a high PEEP, a low tidal volume, very lung protective. Avoid trauma, but you also want to recruit as much of the lung as possible. So that means um, proning the patient early is a great idea, and getting maybe that APRV or bi-level setting on them early if needed, also a great idea, to protect that lung and recruit as much of the lung as possible. Um, but again, all those things very nursing driven, and sort of the foundation is great supportive care, great assessment, and critical thinking to try to advocate for your patient to make those changes if needed to really support them physiologically, um, along the lines of the supportive care, psychologically, psychosocial, get the family involved to prevent that post-ICU sort of PTSD. And this is a very nursing-driven process, and nurses everywhere, not just in the ICU, should be sort of following those things. And with that, thank you to Dr. Morrison, the PLU School of Nursing, the St. Joseph's Medical Center Critical Care Team, the MCRIT and PulmCrit podcast team, all the great articles that I found, and thank you.